great pleasure to move swiftly on to introduce someone who needs very little introduction, Professor John Cleland, currently at the University of Glasgow, heading up quite a large clinical trials unit there, and has a long history of trials in both community and hospital-based heart failure. I'm delighted he's able to join us today to talk. You're going to take us through more of pharmacological treatment and maybe some new things on the horizon. Thank you very much.
Well, thank you very much, and it's a delight to be here. I arrived last night and wandered down to the quay, and I'm actually quite a fan of Morris dancing. So there were Morris dancers down at the quay last night. I had a fantastic free show. Although I did buy the CD, but I'm not going to play it. But really nice, and a fantastic campus here. So, yeah, I'm really impressed by what I've seen. I've been to Exeter once or twice, but not really long enough to really get a feel for the place. So, very nice. So I've been asked to talk about pharmacological therapy. As Andrew says, I've been moving around a little bit, so these are my various titles. And this, Andrew's already shown one of these component slides, and it's this sort of scenario: your patients are doomed. And we've got the scythe here. These are the pictures that you see in every epidemiological paper on heart failure with the progression of disease, patients going to die. Well, perhaps you might sort of pull them back from the brink periodically, or they'll drop dead suddenly. But a very depressing narrative. And actually, it's quite interesting. Where do you think this narrative comes from? And I think the narrative comes from pushing at politicians, the media, and grants givers. So you need to make heart failure important. It's a deadly disease. You're all going to die. And give me some money to sort out the problem. But I actually think that's not the way forward. I think that actually you need to show people that you can do something about it and give a much more optimistic message to the patients and also the funders and the media. Because if they say, well, yes, they can make a difference, but not everybody's getting it, it's a sort of very different message. So we have made great strides in the management of heart failure. My first randomized controlled trial that I ran was on a placebo-controlled trial of captopril back in the 1980s. So I was right in there, and actually one of our trials was shown to the FDA and was possibly tipped the balance for enalapril to be licensed for heart failure. So I've been around for a little while before beta blockers, not before diuretics, I have to say. The MRAs, well, yeah, they were around before me, not the big trials. My trial I'm probably most well known for is the KRHF trial, but I'm not going to talk about devices. You might say, what are anticoagulants doing here? Well, somewhere between 25 and 40% of our patients are in atrial fibrillation. Of course, others will have valves and other reasons for anticoagulants, so there's a big role for anticoagulants. Many of you may know that I'm one of a small but growing group of cardiologists who are extremely sceptical about aspirin. I think it may actually be harmful, as with other non-steroidal anti-inflammatory drugs. And we have some new kids on the block that we'll be talking about during the course of the morning. And of course the latest new drug on the scene, sacubitril valsartan. But this is, to give you some more positive message, this is a slide I made from a study called Comet, where we had very long follow-up on randomized controlled therapy. So almost all the patients followed for 4 years. And you can see at baseline, some of these patients felt quite well, some of them quite sick. And this is how things evolved over the 4 years. And I think it's quite informative. you can see that the proportion of patients who felt very sick really didn't change over that 4 years. Because, of course, these patients who feel very sick are much more prone to die. Some of the patients who were feeling well, okay, they did progress to these poorer health states. But you can see it doesn't really change very much over time. And indeed, there's a bunch of people up here who feel very good or good throughout the 4 years. So it's not gloom and despondency for all of these patients. And you can divide this up into what I call life lost. So this is not just are you dead or are you alive, but do you feel well or do you feel sick? So you can see that some of these patients didn't do very well. There were about 3,000 patients in this analysis. So round about 20% or so felt pretty crook or died pretty quickly. But you've got another 20% up here. And in fact, healthy folk don't report feeling well all of the time. So this 20% were actually doing pretty well throughout the 4 years of follow-up. So sort of good news. And so we just published this editorial trying to change the view from this scenario to this scenario, where we have perhaps 15% of patients over a 3-year period will actually recover. The ventricular function gets better, the symptoms go away, they perhaps don't need to loop diuretics. If it was cancer, we would call this remission. So I talk about cardiac remission. A good number of patients get stabilized. So probably more than half of our patients will remain stable with not too troubling symptoms over a 3-year period. Still a good number of people dying suddenly, and selecting the right patient for defibrillator is still a problem. And we've got about 15% or so patients who will progress over a 3-year period. And so what we've got to do is try and stop this progression and reverse it, try and stop the sudden death, and try and convert more of these stabilised heart failure patients into patients who recover. Of course, there's one big caveat to this, and that is this is what applies to people under the age of 70. The problem is that heart failure is a condition which is associated with aging. If we live long enough, we'll all develop heart failure. So it's sort of an inevitable consequence of aging. This is what we've achieved. If you looked at the very early studies in the 1980s, like the BHEFT-1 study, we take a bunch of patients, average age 58, in class 2 to 3 heart failure. Within 5 years, 60-65% of those patients would be dead. Within 10 years, probably 80 to 90% of those patients dead. First big breakthrough with enalapril, a significant reduction. But then if we throw cardiac resynchronization, ACE, beta blocker, into a rather sicker group of patients, you can see that the 5-year mortality is now down in the region of 30%. And in fact, if you were under the age of 70 in the KRHF study with CRT, you started off as a class 3-4 heart failure patient. If you were under the age of 70, you had a better than 50% chance of surviving 10 years. So quite a change in prognosis. Of course, if you start treatment when the patient's got milder symptoms, you may be even more successful. But age does eventually catch up with you, and you can see in these older patients, mortality still is substantial. And the population is getting older, and many of the patients that we see are not the 40-year-old dilated cardiomyopathy who needs a heart transplant, but rather the 82-year-old who's got multiple comorbid conditions. And we're set to have an ageing of the population. This is one mathematical prediction of what's going to happen. But there are clever mathematicians about who believe that something different is going to happen. And it's going to look like that. So that's going to be quite interesting because it looks much more like an exponential curve than a linear increase in mortality or life expectancy. And it does make you wonder about the Bible at times. Are we heading back to the pre-Diluvian lifestyle? And so you may wonder why I've got Bruce Forsyth on this. Well, he's a pretty good example of an 80-year-old. He had better footwork than I do at the age of 80, well, when I do that. But the point is not for everybody to look this age at 80, but rather at these young ladies, what would happen if they were 80? You might say, well, that sounds a bit ghastly. But of course, if you think of aging as a disease, and I do wonder whether some of the new treatments that are coming through for heart failure are not really orientated at the heart. They are orientated at every cell in the body. They are orientated towards the aging process itself. Because if you're going to try and defeat heart failure, perhaps you actually have to defeat aging itself. Scary, sounds a bit like nuclear physics and the A-bomb and should we do it? Problem is it's very difficult to hold science back. Anyway, back to reality. These are data from the national audit. They're not published yet. I spent one evening going through 70,000 deaths and classifying them all into cardiovascular and non-cardiovascular. So from the national audit now, we can look at cardiovascular mortality and cardiovascular hospitalization, as well as all-cause. And you can see that the prognosis, if you're not stabilized, if you've had a recent hospitalization and decompensation, is pretty poor. Pretty poor regardless of your age, but you can see that age is one of the most powerful prognostic factors, and we have to think about that. Andrew showed you some complex prognostic models, but actually a very simple prognostic model is how symptomatic is the patient, how much diuretic do they need, what's their age, and what's their natriuretic peptide. Once you know those four things, I'm a bit sceptical about whether anything else adds meaningful additional prognostic information. So perhaps we can make it simple. So the original one was waking up, title of this symposium was Waking Up to Acute Heart Failure. That was on the hope that a couple of studies, one called True HF, it shouldn't be True Zero HF, but it did turn out to be a zero, so it's, perhaps that typo is prescient. And the Relax HF studies, there were two big acute studies that were presented this year, and they both bombed, both neutral. Altogether 5,000 or 6,000 patients in these randomized controlled trials. And indeed, all of these trials have one thing in common, which is they're neutral. So we just haven't found good intervention in the modern era for acute heart failure. We'll come on to the reasons for that. But Einstein said that repeating the same thing over and over again and expecting a different result is the definition of madness. And I think that this is a definition of madness, these trials. And the total cost has probably been about £1 billion. So you could have run the NHS for a year on the back of these clinical trials. Hopefully that would have been more useful. So why were they neutral? And it's possibly because the treatment of acute heart failure is largely a met need. This is a study called Urgent, where we took patients who were admitted with acute heart failure. We looked at the breathlessness at baseline and at 6 hours, and you can see immediately that with usual care, an awful lot of these patients had little or no breathlessness within 6 hours, just with diuretics, oxygen, and for the occasional patient, a touch of opiate. In fact, only 36% of patients were admitted with severe breathlessness in the first place. And this is a recurring theme, which is all of these big acute heart failure studies are predicated on the basis that the patient has been admitted in pulmonary edema, needing oxygen with a face mask on, and tachypnea, etc., etc. And that's just not what the trials have recruited. They've recruited people who've walked from the taxi to the wheelchair, got big swollen legs, can't get to the bathroom, can't get upstairs to bed. So they are breathless, but you have to sort of make them do something or lie flat. So only 6% severely breathless by 6 hours with conventional therapy. Very difficult for a new treatment to beat that. So we've spent £1 billion on showing that you can't beat furosemide. And indeed, only one trial has ever managed to randomise patients within 6 hours. So, perhaps if you could get very early when the patients were actually breathless, you could see that you could get them less breathless 30 minutes quicker with a £1,000 drug. You have to say, would the NHS want to pay for that? And this just shows you, we can go back to 2003, I think this is a very nice study from the US, looking at the different symptoms that were associated with admission to hospital. And you can see breathlessness at rest is only around about 20% of these patients admitted in the United States. The edema and weight gain are common problems. They do get breathless if you lie them flat. So as long as they're up having a cup of tea, it's not so bad. And they get breathless walking. So the breathlessness is a problem, but you have to provoke the breathlessness. And the other thing to notice is that these symptoms, as Andrew said, occur quite some time before the admission. And that sort of brings us down to these bloaters and puffers. This is stolen from the respiratory team, but they don't like using puffers and bloaters anymore, I understand. So now in heart failure, we can steal their terminology. So we've got the puffers, the acute pulmonary edema. That's what all the clinical trials have been targeted at, but they're the minority sport. The commoner group of patients appears to be the bloaters, epidemiologically. And of course, these patients are not an acute emergency. These are the sorts of patients who are seen by the GP or the community nurse saying they're not thriving at home, they need to come into hospital to get sorted out. Can they come in tomorrow? And so that's the sort of patient. We've actually been trying to recruit these into a clinical trial, and I have to say in the UK, we've managed to recruit one. We've managed to recruit 200 in the rest of Europe. So I'm a little bit disappointed. That's probably because we haven't got Andrew as an investigator. They never took my recommendations in terms of investigators. But we're really looking for these bloated patients and running one of the first clinical trials in that area. There are a lot of other potential treatments out there as soon as we've got the confidence that we can actually recruit that population. So if you have any great ideas, let me know, because I'd be very grateful. If we look at the national audit data, you can see that there's plenty of patients with severe edema in the national audit data. A lot of these patients are not breathless at rest, which is one of the other things that provoked our interest. And it's the edematous patients who do particularly badly. Okay, so that's a little bit of overlap with Andrew, and but I thought well, that's the talk I prepared, so if you don't have overlap, you have gaps. So I'll progress now and talk a little bit about the Esc Guidelines. Oh, I lost the slide. Oh, yeah, slides are a little bit out of order there. So lots of things we could say about the guideline. It's there to read, and I don't just want to reiterate it all. I thought it make some key points. Surprisingly, this is the first heart failure guideline that makes any recommendations on prevention or management of a pre-symptomatic patient. So that's a little bit curious that it's taken us this long in the guidelines to get round to the idea that perhaps treating the patients earlier is a good idea. We'll just look at the table, and we don't have time to run through it all. Key thing I want to say is that good treatment of hypertension is really essential. If you want to reduce stroke, if you want to reduce heart failure, even if you want to reduce myocardial infarction, it's not so much the statins that will do this. I think the statins help, but it's good control of blood pressure is the number one, along with smoking, stopping smoking. These are the most important cardiovascular preventive strategies. And even if you're elderly, these are a study called HIRET in patients over the age of 80, treated with indapamide and perindopril. You can see that there was a 64% reduction on intention to treat. And I think it was something like 75% if they actually took the tablets, because of course this is intention to treat. They're on these curves whether they take their tablets or not. So huge impact, and probably especially in the HFpEF population, which I think is driven by hypertension. So an important message there, but other things that you can do. And I'm partly responsible for this, and a lot of people don't like guidelines to be very innovative. I think there's a balance to be struck between fossilization of guidelines and innovation. So this is one of the key innovations, which was the introduction of this new phenotype, the HFmref type. So you've heard about the HFrEF, and we'll talk a lot more about that. That's the ejection fraction less than 40%. This is HFpEF, ejection fraction above 50%, and a group in the middle. And the reason for the group in the middle is 39% HFrEF, 41% HFpEF. That can't be right. We know that echocardiography is just not that accurate. So a demilitarized zone in the middle meant that, at least for a clinical trial perspective, we have a clear separation between the HFrEF and HFpEF. So now we know what we're doing. A bit like acute heart failure, we didn't know what we were doing because we called it acute, and then we didn't think about it anymore. And we imagined that acute was acute pulmonary edema, and you can see what a mess you end up in. So now we've got a demilitarized zone. We can, in our clinical trials, if we really want to know that something has worked for HFpEF, it will be very clearly different from those in HFrEF. And we've got this group in the importantly, the importance of natriuretic peptides here. You have to have elevated natriuretic peptides. For me, natriuretic peptides are the diagnosis of heart failure, so they're never wrong, because that's the diagnosis. It's just like, I'll think of another example. Chronically high blood glucose with a raised hemoglobin A1C is diabetes. So I think a raised natriuretic peptide is heart failure. It's just a problem that sometimes it's renal as the cause of the congestion. But there's been an interesting spin-off, which is the HFrEF was basically some people gathered in a pub in Boston one weekend and decided that 40% should be the cut-off for HFrEF. Well, why not? Nobody can tell us what to do, so we just decide on 40%. But now we're going back and looking at the trials, it seems that all the drugs that work for HFrEF also work for this group. So in fact, in that Boston pub, we probably should have chosen 50% for HFrEF and not 40%. But I think it's good to have this grey zone, and I think it's going to stimulate research in this area. So a lot of skeptics, a lot of people have made fun of how ridiculous it is to have this new group. I think it's actually going to be a real stimulus to research. You've already seen this algorithm. I'm sure this is the algorithm that you're practicing in your clinics. We've got diuretics down here for the relief of congestion. We've got think about defibrillators for regardless of the symptomatic severity of the patient. Indeed, it's probably the patients who have the least heart failure symptoms. So a well patient with a sick ventricle are the people who really probably benefit from an ICD. So it's often quite a difficult conversation because the patient sort of feels fine, but if the echo doesn't look fine, that's probably the ideal candidate for an ICD. All patients basically should get an ACE inhibitor and a beta blocker, and in my view, if they need a diuretic, then a mineralocorticoid receptor antagonist should be part of that regime. If the patients have a low ejection fraction, then we need to think about replacing the ACE with an ARNI, and I'll come on to that in more detail. I'm not going to talk about a resynchronization. Ivabradine, again, a lot of controversy about exactly what the benefits of ivabradine are. I think we'll look back in 5 years and think that we were a little too sceptical about ivabradine. We certainly, it's a pity that we're not going to see more industry-supported research for ivabradine. I think that the license has run out, so the price is going to drop. And I suspect as the price drops, the use will increase. So I think it's an undervalued drug. We've got some other things down here. So what's new? And I thought I'd talk a little bit about new things about old therapies, and new potentially available therapies, and then a little bit of future gazing. The first one is a sort of old-new tandem. So I guess the renal physicians will know about patiromer. So this is a potassium binding agent. So for the management of hyperkalemia. And we were talking last night, and it's clear that with ARNIs and ACEs and other things that you are seeing some problems with hyperkalemia. Big issue about whether you back off on the ACE inhibitor and manage the hyperkalemia that way, or should you give them patiromer and prevent the hyperkalemia and keep them on the higher dose ACE inhibitor? We don't really know the answer to that. I'm sure that both strategies will be perfectly reasonable clinically, provided the payers are going to pay for it. Where I think could be a real advantage to the introduction of patiromer is the ability for us to start using much higher doses of mineralocorticoid antagonists. When I were a lad, before the ACE inhibitor era, then we were commonly using 200 milligrams of spironolactone. In the consensus study, the average dose of spironolactone in that ACE inhibitor study was 80 milligrams per day. So we used to use much higher doses of MREs, and it's only because of the problems with hyperkalemia that we've gone for much lower doses. So there's a potential advance here that we can, for our patients where recurrent congestion is a problem, perhaps we can give them higher doses of MRAs and then deal with the hyperkalemia with patiromer. The only problem will be perhaps there are other reasons why the dose of MRA is limited. Blood pressure, renal function, as well as just the potassium, but certainly worth exploring. A little bit of discussion earlier about the CKD, and in fact I think there is this, heart failure is a bit of a car crash. between arrhythmias, atrial fibrillation in particular, the heart failure, and renal dysfunction. And all of these are age-related phenomena, so you can see that that's, in a sense, age is the common link between these comorbidities. The reason why I brought that up is that there's a series of drugs that we have which the atrial fibrillation in particular seems to have an important bearing. First of these is digoxin, and after 200 years we're still not clear whether we should be using digoxin in heart failure yet. This is from Deepak Tekka's work, and looking at all of the clinical trial data on digoxin, and basically saying that the higher the quality study, the more likely the study is to be neutral, that all of these studies that suggest that there is a problem with digoxin, they're poor quality studies, and it's usually because the digoxin's been prescribed because it's a sicker patient, and sicker patients die more. So the digoxin is an indicator that the patient's on a bad course. But when you do well-designed randomized controlled trials, it looks much more neutral. Now, these studies were conducted before MRAs and beta blockers were being used commonly, and it's possible that digoxin now works much more effectively than it did before, because beta blockers and MRAs there's worry that digoxin may increase the risk of sudden death. On the other hand, if digoxin is working by slowing heart rate, then beta blockers can do that much more effectively. And indeed, excessive reduction of nocturnal heart rates, which is something we worry about, and I don't know if you do, might be provoked by digoxin. So it may be that digoxin has become less safe. We really don't know. This, I guess, was the shock of a year, 18 months ago, when we put all of the data together from the big beta blocker studies. You could see very clearly that around about 30% reduction in mortality for the patients in sinus rhythm, and diddly squat for the patients in atrial fibrillation. And every way we look at this, we can't see a benefit from beta blockers in atrial fibrillation. There's two ways of thinking about this. One is beta blockers are just useless in atrial fibrillation, they don't work. Or the other one is that they do work, but they have a toxic side effect. And every drug is the net good and the net, it's the good and the bad they do, and then you get the net result. So maybe there is a downside. And so my suspicion is that these patients are developing excessive nocturnal bradycardia, and that may be a digoxin-associated phenomenon. We don't have the conclusive proof for that yet, but so it's a working hypothesis. But one thing we do know is if you look at the patient's ventricular rate at clinic, if it's less than 70 beats per minute, the risk goes up. So in my practice, if I've got a patient with stable heart failure and atrial fibrillation with a heart rate less than 70, the first thing I do is I stop the digoxin, see if the heart rate comes up. If it doesn't come up enough, then I start to back off on the dose of the beta blocker, because the evidence of a dose response with beta blockers in terms of morbidity and mortality is really not there. So I think this phenomenon might be related to excessive ventricular rate control and nocturnal pauses. If you have 4 or 5 second pauses at night, then that might trigger VT and death. Yep, okay. So ivabradine, I can't say too much more about this other than that more analysis are going on of the SHIFT study. You're all aware that the ivabradine works better if heart rate is higher. If you're not taking a beta blocker, and interestingly, ivabradine seems to produce exactly the same result as a beta blocker if you're not on a beta blocker. And I think people have been very slow at coming forward as ivabradine as an alternative, and I think that there's almost been a religious persecution of ivabradine in that setting. And I would very happily use ivabradine if the patient refused, couldn't take, or was contraindicated for a beta blocker. And the other thing is, it's interesting in younger patients with dilated cardiomyopathy, perhaps there is a bigger benefit. And I think it's a shame if people go to heart transplantation without a trial of ivabradine. I always give ivabradine. I guess I should spend my last 5 minutes on ARNIs. So everybody aware of ARNIs, a new group of drugs. These are a molecule which is a precursor broken down by the liver into valsartan, which is an angiotensin receptor blocker, and a neprilysin inhibitor, which blocks the degradation of BNP and many other peptides as well. If you give sacubitril valsartan, you'll cause a rise in BNP because you're slowing degradation. But there'll be a fall in NT-proBNP because you've dropped left atrial pressure, and that reduces secretion. So they did a very complex study called Paradigm HF. They had to do that because the regulators forced them to, because they wanted to show that this new drug, Entresto, was superior to enalapril, and they had to show that it was superior to enalapril in a proper dose. So they went through this complex regime, which meant that they could only ever really treat very stable patients. So we don't have a lot of experience in using this in unstable patients, and I think starting this drug in patients with a recent decompensation, I think is something you have to do with great care. This clinical trial is conducted in very stable patients. A few pointers about them. They were predominantly NYHA2, so it's the stable patient that you should be after, but also rather high NT-proBNPs. So these are a bit like the defibrillator patients. These are mildly symptomatic patients who carry high cardiac risk. So it's that combination population. And all of these patients had to have an NT-proBNP above 4 to 600 picograms per mole, nanograms per liter. This is the impact of the study, so around about a 20% reduction in cardiovascular death, in hospitalization for heart failure. This is, of course, as in all of these studies, an intention to treat analysis. So I think these always underestimate the real benefits of drugs, because in an intention to treat analysis, you're randomized to a treatment. It doesn't matter whether you take it or not. You're still counted in that group. It is the most robust analysis, but it probably underestimates the real impact in clinical practice. And of course, you may say, well, 20%, is that so much? But it is against enalapril, which already has reduced mortality by 20-25%. So I think compared to a placebo, this probably has double the effect of an ACE inhibitor, and the impact appears quite early. We looked at this in our clinic about how many patients were eligible, and these are all the various eligibility criteria for the clinical trial. And you could see that it was only around about 20% of the patients with HFrEF attending our clinic in Hull who were suitable for Entresto. So now, of course, this is using the Esc Guideline. This is using the clinical trial criteria. If you look at the license from the NICE or the MHRA or FDA, they don't care about your NT-proBNP or these other things. They just say you've got symptomatic heart failure with a low ejection fraction. So it would be a far larger proportion of patients if you go by NICE criteria rather than the guideline criteria. But one of the reasons why I think NT-proBNP is important in this setting is look at the mortality of the patients who have an NT-proBNP below 400 or 600 nanograms per litre. These patients are average age around about 70. the normal healthy population is probably down about 1 or 2% mortality. It's unlikely that sacubitril/valsartan could be cost effective. So I think this is why you should get your NT-proBNP everywhere, which is the NT-proBNP, even with the add-on lab cost, shouldn't cost you more than £14. If not, send it to Hull, because that's all it costs in Hull to get your NT-proBNP measured. So £14 as opposed to, how much is it per month for sacubitril/valsartan? Over £100, yeah, 100, probably 100 if you get a good deal, 150 if you don't. So you can pay for as much NT-proB as you like on the basis of just a handful of these patients. Yeah, so I'll probably stop at that point because I know you want coffee. If one of the speakers doesn't turn up in the afternoon, we can do the rest.